Welcome. We'll be discussing Esodeviations in two sessions. In this session, we'll be discussing the two most common forms of childhood esodeviations, namely accommodative esotropia and infantile esotropia. The remaining types of esodeviations, both in children and adults, we'll be discussing in the next session. An esodeviation is a convergent misalignment between the visual axes of the two eyes, and this misalignment can be either latent or manifest. A latent esodeviation is called an esophoria, and a manifest esodeviation is called an esotropia. And we have discussed the difference between phoria and tropias in the session on motor evaluation of strabismus. Esodeviation is the most common type of strabismus in children, but in adults, esodeviations and exodeviations occur in equal proportions. Amblyopia develops in 50% of children with esodeviation. This is in contrast to exotropia, in the most common form of which, namely intermittent exotropia, amblyopia does not usually develop. Risk factors for esodeviations include refractive errors such as anisometropia and hyperopia, prematurity, low birth weight, craniofacial anomalies and developmental neurological impairment, maternal smoking during pregnancy, and family history of a strabismus, which can be either esodeviation or exodeviations. Classification of esotropias is very important to understand and to remember. Like other deviations, esodeviations can be classified as committant or incomitant. In committant esodeviations, the magnitude of deviation for distance fixation is same in all positions of gaze. And among committant deviations, we have congenital or infantile esotropia, in which by definition the esotropia becomes manifest before 6 months of age. Whereas in acquired esotropia, the onset of esotropia is usually after 6 months of age and can be as late as adulthood. In accommodative acquired esotropia, which usually occurs in children, the magnitude of esodeviation can be rectified either completely or partially by correction of refractive error. And in non-accommodative acquired esotropia, the magnitude of esotropia cannot be rectified by correction of the refractive error. And we have several entities which we will be discussing in the acquired non-accommodative group. And we have incomitant esotropias, in which the magnitude of esotropia for distance fixation varies with the position of gaze. Incomitant esotropia can be caused by palsy of the sixth cranial nerve, which causes weakness of the lateral rectus muscle, congenital cranial disinnervation disorders, which are also known as CCDDs, such as Duane's syndrome and Mebius syndrome, which we will be discussing on the session on special motility disorders, medial rectus restriction, which may be caused by thyroid-related ophthalmopathy, medial orbital fracture with entrapment of the medial rectus muscle, or excessive resection of the medial rectus muscle in a patient with exotropia. In high myopic patients, there can be lateral prolapse of the posterior portion of the globe, leading to esotropia. And iatrogenic weakening of lateral rectus muscle can also lead to incomitant esotropia, and this can result from excessive recession of the lateral rectus muscle or a slipped or lost lateral rectus muscle during surgery. Pseudoesotropia is the appearance of esotropia with normally aligned visual axis. And the causes of pseudoesotropia include a broad nasal bridge as seen here in this photograph, narrow interpupillary distance, epicanthal folds, and negative angle kappa. And patients with ability to converge on very near targets can also appear esotropic. Pseudoesotropia is most apparent when the eye moves laterally, because when the eye abducts, the area of the nasal sclera being visible appears to be very small in pseudoesotropic patients. But results of cover test and corneal light reflex test are normal in pseudoesotropia, demonstrating that the two visual axes of the two eyes are aligned, except in patients with negative angle kappa, in which the corneal light reflex does not appear in the center of the pupil despite the two visual axes being aligned. Pseudoesotropic patients can later develop strabismus or refractive errors, so it is important to monitor these patients long term. Accommodative esotropia is the most common esodeviation in children and is an acquired esotropia associated with activation of near reflex. The near reflex consisting of accommodation, convergence, and meiosis. Onset of accommodative esotropia can be between 4 months to 7 years of age, but is usually between 2 to 3 years of age. Accommodative esotropia is never present at birth. As we have discussed, accommodative esotropia is a comitant esotropia and needs refractive correction to control esotropia, as we see in these photographs. So this patient with an esotropia becomes orthotropic after spectacle correction of his refractive error. Accommodative esotropia can occur with a normal or a high AC by A ratio, as we will be discussing soon. Accommodative esotropia is initially intermittent but later invariably becomes constant. In the intermittent phase, the esotropia is usually noted when the child is tired or inattentive. Initially, the child can complain of diplopia or asthenopia, but diplopia and asthenopic symptoms disappear later with development of suppression. And by definition, in accommodative esotropia, after appropriate refractive correction, deviation for distance fixation decreases to less than 10 prism diopter. But if after appropriate correction of refractive error, the esotropia decreases partially and residual esotropia of more than 10 prism diopter persists for distance fixation, then it is said to be a partially accommodative esotropia. Uncorrected accommodative esotropia is frequently associated with amblyopia. Accommodative esotropia with normal AC by A ratio is also known as refractive accommodative esotropia and occurs due to a high hyperopia on an average of +4 diopters. Because of this high hyperopia, the patient has to accommodate to focus a distance target and has to accommodate more for focusing a near target. As part of the near triad, convergence occurs along with this accommodation, and the patient has inadequate fusional divergence amplitudes to overcome this convergence. The magnitude of esodeviation in refractive accommodative esotropia is usually between 20 to 30 prism diopters and is similar for near fixation and distance fixation. In contrast, in accommodative esotropia with high AC by A ratio, we will find that the refractive error is in the normal range and the esodeviation is more for near fixation as compared to esodeviation for distance fixation. Since accommodative esotropia with normal AC by A ratio occurs due to a high hyperopic refractive error, treatment of this condition is cycloplegic refraction and full correction of this hyperopic refractive error. With full correction of this hyperopic refractive error, patients no longer need to accommodate to focus on a target and thus do not need to induce convergence. Parents of the patient must be counseled about the need for full-time wear of spectacles and also should be made aware of occurrence of esotropia whenever spectacles are removed, with this esotropia often being larger and more frequent than the esotropia occurring before onset of spectacle wear. After initial prescription, the child is re-evaluated after 1 month to ensure absence of asthenopic symptoms and control of deviation to less than 8 prism diopters for both distance fixation and near fixation. Since hyperopic refractive error can increase in a child till 5 to 7 years of age before starting to decrease, cycloplegic refraction, visual acuity monitoring and measurement of the deviation needs to be repeated at regular intervals, usually every 3 to 6 months depending on the age of the patient. If the patient is detected to have amblyopia at diagnosis or on follow-up, amblyopia therapy should also be instituted, and we have discussed the methods of amblyopia therapy in the session on amblyopia. Accommodative esotropia with high AC by A ratio is also known as non-refractive accommodative esotropia, and it occurs due to excessive convergence relative to the amount of accommodation required for focusing at near. So in accommodative esotropia with normal AC by A ratio, which we have just discussed, the amount of convergence for the amount of accommodation is normal. But since the amount of accommodation is high because of the high hyperopia, the amount of convergence is also high. But in accommodative esotropia with high AC by ratio, the amount of accommodation is normal because, as we will see, the refractive errors in this patient can be in the normal range. But in these patients, the amount of convergence for the amount of accommodative effort induced is high, which is known as a high AC by A ratio. In patients with high AC by A ratio accommodative esotropia, esodeviation occurs with near fixation even after full refractive correction for distance. So with the full distance correction in place, when the patient induces accommodation for near fixation, the accompanying convergence is excessive, and so the eyes appear esotropic at near fixation. These three photographs show a patient with high AC by A ratio accommodative esotropia wearing bifocal glasses, which, as we will be discussing, is the treatment modality for high AC by A ratio accommodative esotropia. This photograph shows that when the patient fixates on a distance target through the distance portion of the bifocal glasses, the eyes appear orthotropic. But when the patient fixates on a near target through the distance portion of the bifocal glasses, the eyes appear esotropic. And this photograph shows that when the patient fixates on a near target through the near segment of the bifocal, the eyes are orthotropic, because when the patient fixates on a near target through the near segment of the bifocal glasses, the patient no longer needs to induce accommodation to focus on a near target, and so the accompanying convergence movement is also not stimulated. So in high AC by A ratio, we find esodeviation greater at near fixation than at distance fixation, with the esodeviation at near fixation being at least 10 prism diopters more than esodeviation at distance fixation. So this 10 prism diopter excess esodeviation at near fixation is a rule of thumb to detect high AC by A ratio, and we do not need to calculate AC by A ratio routinely in the clinic. Also, esodeviation at near should be measured in primary position and not in down gaze, which is the usual reading position, because esodeviation in down gaze also occurs in V pattern esotropia, which we might confuse with high AC by A ratio accommodative esotropia if we measured esodeviation at near in down gaze instead of the primary position. And if the esodeviation in high AC by A ratio accommodative esotropia is intermittent, the esodeviation can be unmasked by cycloplegia, because that makes the patient induce an accommodative effort, and the accompanying convergence is also unmasked. The average refractive error in a patient with high AC by A ratio accommodative esotropia is in the normal range and is around plus 2.5 diopters, and it has been seen that high AC by A ratio accommodative esotropia, since it does not actually depend on hyperopic refractive error at distance, can occur with high hyperopia as well as with emmetropia or myopia. Treatment of high AC by A ratio is mainly optical. In addition, amblyopia therapy may be required if necessary. Optical treatment of high AC by A ratio accommodative esotropia is the prescription of bifocal ads over the full distance cycloplegic refraction. The minimum ad required to control esodeviation at near should be prescribed and is usually less than plus 3 diopters. Flat dot bifocals are usually prescribed with the top of the segment high enough to bisect the pupil in the primary position. Ideal response following optical correction of high AC by A ratio accommodative esotropia is achievement of fusion for both distance fixation and near fixation. An acceptable response is achievement of fusion at distance and less than 10 prism diopters of esodeviation for near fixation. As the high AC by A ratio in these patients gradually decrease with age, the bifocal ads can also be gradually reduced after the child attains 7 to 8 years of age. When the parents of the patients note the child having less esotropia when not wearing the correcting glasses. Instead of optical correction with bifocal spectacles, many experts recommend observation only with monofocal glasses for distance correction if required, so long as fusion at distance fixation is present. Because the high AC by A ratio in these patients, as we have just discussed, decreases with time, and because many of these patients with high AC by A ratio without being given bifocal spectacles ultimately develop fusion for both near as well as distance fixation. Surgery for accommodative esotropia is controversial. This is in contrast with congenital or infantile esotropia, in which surgery is the treatment of choice, and this difference is very important to remember. In partially accommodative esotropia, one component of the esotropia is accommodative, but the remaining amount of esotropia is not. So after full cycloplegic refraction, the magnitude of esotropia decreases but does not disappear, and a significant amount of residual esotropia, more than 10 prism diopter for both distance fixation and near fixation, still exists. Also, the accommodative component in partially accommodative esotropia can be normal AC by A ratio or high AC by A ratio accommodative esotropia. In the former, we will find similar esodeviations at near fixation and distance fixation without spectacle correction, and in the latter, we will find a greater esodeviation at near fixation as compared to distance fixation without spectacle correction. Treatment of partially accommodative esotropia is surgical correction of the residual non-accommodative component of the esotropia, followed by optical correction of the accommodative component of the esotropia. This follows the principle that accommodative esotropia should not ideally be corrected by surgery. Infantile esotropia, also called congenital esotropia but more appropriately termed infantile, is defined as presence of esotropia by 6 months of age. So this is a very important figure to remember. But even in this condition, esotropia is rarely present at birth. It is often associated with prematurity and neurodevelopmental problems. Infantile esotropia must be differentiated from strabismus of early infancy, which are variable and intermittent in nature, can be exotropia or esotropia, and which disappeared by 3 months of age. And it has been found that if constant esotropia of more than 30 prism diopter is present after 2 months of age, it is unlikely to disappear spontaneously. Infantile esotropia is characterized by constant esotropia of more than 30 prism diopters, and this esodeviation remains same in all positions of gaze as well as for distance and near fixation. Since it remains same in all positions of gaze, infantile esotropia is a comitant esotropia, as we have discussed previously. Visual acuity of a patient with infantile esotropia may be equal in both eyes, or one eye may be amblyopic. If visual acuity is equal in both the eyes, there can be cross fixation or alternate fixation. Cross fixation is an important term for infantile esotropia, wherein each eye is used to fixate on objects in the contralateral visual field. So when we move a target from the right visual field to the left visual field, when the target is in the right visual field, the left eye fixates on the target, and when the target is moved across to the left visual field, the right eye takes up fixation of the target. So the patient has no need to abduct an eye for ipsilateral gaze. As seen in this diagram, when the target is in the right visual field, the right eye does not abduct to take up fixation, while the left eye maintains fixation on the target in the right visual field, and the same happens when the target is in the left visual field. We also see that in this situation there is lack of binocularity, which we will be discussing further. Because of this apparent lack of abduction of eye in cross fixation, each eye appears to have an abduction deficit, and this abduction deficit is called pseudoabduction deficit. But full abduction of each eye is actually present and can be demonstrated by Dolce maneuver, occluding one eye or spinning the child. So as seen in this diagram, with the target positioned in the left visual field. A cross-fixating child with infantile esotropia maintains fixation on the target with the right eye, and the left eye does not abduct to take a fixation on that target. But now if we occlude the right eye, the left eye does abduct to take a fixation of the object in the left visual field. But if instead of visual acuity being same in both the eyes, if one eye is amblyopic, the fellow eye with normal visual acuity is used to fixate in all positions of gaze, and only the amblyopic eye appears to have an abduction deficit in its ipsilateral gaze. In infantile esotropia, refractive errors are usually in the normal range, but if a larger hyperopic refractive error is detected, accommodative esotropia has to be ruled out by excluding decrease in the magnitude of esodeviation with spectacle correction. In long-standing esodeviation, restriction of medial rectus muscle can develop, leading to actual abduction deficit, which can be detected with forceduction testing. Ciancia syndrome is a particular type of infantile esotropia with a large angle esodeviation of more than 50 prism diopters along with cross-fixation. In these patients, abductive nystagmus also occur. Characteristic associated abnormalities can occur in patients with infantile esotropia in addition to their esodeviation. Among them, overelevation in adduction and dissociated strabismus occur in more than 50% of patients but develop after 1 to 2 years of age. So overelevation in adduction and dissociated strabismus is not found in infantile esotropia patients during their infancy. Overelevation in adduction is due to inferior oblique overaction, and this diagram shows overelevation of the right eye in adduction in a patient with esotropia. Overaction of inferior oblique muscle causes this overelevation in adduction because, if we recall, in adduction, inferior oblique is the primary elevator, and it has been found that early correction of infantile esotropia does not prevent overelevation in adduction to develop later. And this overelevation in adduction can occur in one eye or in both the eyes when each adduct. In dissociated strabismus, we will find intermittent slow movements of one eye only of the patient. Since only one eye moves, it is called dissociated. And this movement is most commonly an elevation when it is called a dissociated vertical deviation, but can also be an excyclotorsion when it is called a dissociated torsional deviation, or abduction when it is called a dissociated horizontal deviation. This movement of one eye only can affect either one eye or can affect both the eyes. And dissociated strabismus can be either manifest or latent. In manifest dissociated strabismus, we will be observing movement of one eye even when both the eyes are open. And in latent dissociated strabismus, this movement occurs only upon occluding one eye, and the movement occurs in the eye being occluded. And upon removal of the occlusion, we will find that the eye again takes a fixation by reversing the movement. And what is characteristic of dissociated strabismus is that when the eye which has moved out of position again takes a fixation, the fellow eye does not deviate towards the opposite side. For example, in dissociated vertical deviation, the deviating eye elevates, and when it depresses to again take a fixation, the fellow eye does not depress and does not become hypotropic. Asymmetry of monocular horizontal smooth pursuit is very characteristic of infantile esotropia patients and can be demonstrated with an optokinetic nystagmus drum. So when the patient is made to follow a target from the right half of the visual field to the left half of the visual field, we will find that the right eye, which moves nasally, follows the target very efficiently, but the left eye, which moves temporally, does not. And when the target is moved from the left side to the right side, the left eye, which moves nasally, follows the target very efficiently, but the right eye, which moves temporally, does not. This directional asymmetry of monocular horizontal smooth pursuit occurs in patients with infantile esotropia, with nasal to temporal smooth pursuit being more disturbed than temporal to nasal smooth pursuit. This asymmetry of monocular horizontal smooth pursuit is present in normal infants up to 6 months of age, but in patients with infantile esotropia it persists throughout life and is considered as a lifelong perpetual marker of infantile esotropia. So this asymmetry of monocular horizontal smooth pursuit occurs in all patients with infantile esotropia, but the other associated features which we are discussing are found in only some patients with infantile esotropia and not all. Fusion maldevelopment nystagmus syndrome, also called FMNS or latent nystagmus, is another associated feature of infantile esotropia and occurs in as many as 50% of patients with infantile esotropia. In FMNS, when one eye is occluded, we will find that the unoccluded eye has a jerk nystagmus with the fast phase towards the unoccluded eye. This jerk nystagmus actually occurs in both the eyes with the fast phase in the direction of the unoccluded eye, and on occlusion of the other eye we will find that the direction of the fast phase of jerk nystagmus reverses towards the now unoccluded eye. Since in latent nystagmus patients occluding one eye induces nystagmus in the unoccluded eye, latent nystagmus can interfere with visual acuity recording, and it has been found that in patients with latent nystagmus, fogging the fellow eye with a plus powered lens or a translucent lens over the fellow eye induces less nystagmus in the unoccluded eye as compared to occlusion of the fellow eye, and allows a better visual acuity measurement of the unoccluded eye. Nystagmus blockage syndrome is another associated feature of infantile esotropia, which can occur in up to 10% of patients with infantile esotropia. In nystagmus blockage syndrome, each eye has nystagmus more when the eye is abducted than when the eye is adducted. In contrast, nystagmus of FMNS or latent nystagmus occurs equally in all positions of gaze. Because of this increased intensity of nystagmus in abduction compared to adduction, patient induces convergence to adduct both the eyes so as to minimize the nystagmus and thus improve visual acuity. In infantile esotropia patient with nystagmus blockage syndrome, it may not be possible to neutralize the esodeviation and thus measure the esodeviation with prisms, because the prisms straighten the eyes and thus provoke nystagmus, which induces further convergence and which requires additional prisms to neutralize, and the cycle continues. Aims of treating a patient with infantile esotropia includes excellent visual acuity in both the eyes, that is prevention of amblyopia development, aesthetic alignment of the eyes, and perfect single binocular vision, that is fusion and stereopsis in all positions of gaze in distance and near. The first two aims, excellent visual acuity and aesthetic alignment of the eyes, are usually achievable, but perfect single binocular vision with high-grade stereopsis is rarely achievable, and this is important to remember that infantile esotropia patients rarely develop bifoveal fusion even if surgical correction is done early in life. Instead, following surgical correction, they develop monofixation, in which there is central suppression but peripheral fusion develops, and this peripheral fusion provides stable alignment between the eyes. And this development of monofixation following surgery instead of developing bifoveal fusion is actually considered to be a successful surgical outcome in patients with infantile esotropia, and this is very important to remember, that patients with infantile esotropia rarely achieve bifoveal fusion and usually develop monofixation following surgical correction of their esotropia. Surgery is the treatment of choice for infantile esotropia, and this contrasts with accommodative esotropia, in which optical correction is the treatment of choice. Surgery should be performed before 2 years of age to achieve at least some degree of binocularity, and it has been seen that the earlier surgical realignment is achieved, the better is the final binocular status of the patient. Although perfect single binocular vision is rarely achieved in patients with infantile esotropia. Preoperative amblyopia therapy with refractive correction as required is helpful in patients with infantile esotropia. but it has been seen that patients with mild to moderate amblyopia do not need to undergo amblyopia treatment preoperatively to maintain successful post-operative alignment of the eyes. So in patients with mild to moderate amblyopia, surgical realignment do not need to be deferred, but of course, if surgical alignment is done prior to institution of amblyopia therapy in mild to moderate amblyopia, amblyopia therapy must be instituted and continued as required following surgical correction of the esodeviation. And there are several reasons why preoperative amblyopia therapy in a patient with infantile esotropia can be helpful. And to determine the amount of surgery, the deviation is measured with the full correction of refractive error in place. Because if associated significant hyperopia exists and we measure the deviation without the spectacle correction of this hyperopic refractive error, the convergence induced by this uncorrected hyperopic refractive error will be included in the esotropia, and the esotropia will subsequently be overcorrected, resulting in postoperative exotropia. The most commonly performed initial surgery in patients with infantile esotropia is bilateral medial rectus recession, and this is important to remember. Recession weakens a muscle, so recession of medial rectus muscle will weaken its adducting effect and will thus neutralize the inward deviation of esotropia. But unilateral surgery is recommended with medial rectus recession and lateral rectus resection being performed in the same eye in patients with poor vision in one eye due to amblyopia or other causes, and the unilateral surgery is performed in the eye with the poor vision so as to avoid complications of surgery in the better seeing eye. In resection, the strength of a muscle is increased by shortening the muscle, and resection of lateral rectus muscle thus enhances its abducting effect and neutralizes the inward deviation of esotropia. But with larger esotropias of more than 60 prism diopters, 3 or all the 4 horizontal rectus muscles may need to be operated on. Surgical dosage refers to the amount of muscle adjustment required for a specific amount of deviation measured. For bilateral surgery, recession of each MR muscle in millimeters is given as follows for a corresponding amount of deviation measured. And for unilateral surgery, the amount of recession of medial rectus muscle in millimeters and the amount of resection of the ipsilateral lateral rectus muscle in millimeters is also given for corresponding amount of deviations measured. We may note here that the amount of recession of medial rectus muscle in unilateral surgery is equal to the amount of recession of each medial rectus muscle in bilateral surgery for a specific amount of deviation measured, and the amount of resection of the ipsilateral lateral rectus muscle is 1 millimeter more than the amount of recession of the ipsilateral medial rectus muscle in unilateral surgery. Many children with infantile esotropia require a second or a third surgery later on during their childhood, and then the previously non-operated muscles are usually operated on. Dissociated vertical deviation requires surgical correction by superior rectus recession, which weakens the superior rectus muscle, and inferior oblique overaction causing over elevation in adduction requires an inferior oblique weakening procedure, which can be recession, myotomy or myectomy of the inferior oblique, or anteriorization of the inferior oblique to the margin of the inferior rectus muscle. Botulinum toxin has been used as an alternative to surgery for small angle infantile strabismus, but multiple injections under general anesthesia are required in these patients, and botulinum toxin as a treatment option for infantile strabismus is not uniformly recommended. So an optimal acceptable result of surgical correction of infantile esotropia is reduction of the esodeviation within 8 prism diopters of orthotropia, or in other words, achievement of monofixation. Here we may recall that the size of a central suppression scotoma of monofixation is less than 8 prism diopters. Long-term follow-up of patients undergoing surgical correction of infantile esotropia is required to detect the occurrence of inferior oblique overaction, dissociated deviations. We may recall that inferior oblique overaction and dissociated deviations have an onset after 1 to 2 years of age. FMNS or latent nystagmus, amblyopia development, and development of an accommodative component to the esotropia. To recap the salient points, esotropia is the most common deviation in children. Esotropia is classified as committant or incomitant. Committant esotropia is further classified into infantile esotropia, acquired accommodative esotropia, and acquired non-accommodative esotropia. Acquired non-accommodative esotropia is further classified into several entities, which we will be discussing in the next session. Accommodative esotropia is the most common type of esotropia in children, and onset of accommodative esotropia is between 4 months and 7 years of age, usually between 2 to 3 years of age. Accommodative esotropia can be with normal AC by A ratio or with high AC by A ratio. Accommodative esotropia can also be partially accommodative. Normal AC by A ratio accommodative esotropia is due to high hyperopia with esodeviation at distance fixation and at near fixation being almost similar, and treatment of normal AC by A ratio accommodative esotropia is full hyperopic correction after cycloplegic refraction. High AC by A ratio accommodative esotropia is due to excess convergence for a certain amount of accommodation induced by the patient. These patients usually have refractive error in the normal range, and in these patients, esodeviation at near fixation is at least 10 prism diopters more than esodeviation at distance fixation. Patients are treated with bifocal ads over their distance correction, if any. Partially accommodative esotropia, esodeviation at distance is at least 10 prism diopters or more even after full refractive correction. Partially accommodative esotropia can also be with a normal AC by A ratio or a high AC by A ratio. The non-accommodative component of partially accommodative esotropia is corrected surgically, whereas the accommodative component of partially accommodative esotropia is treated by refractive correction. Infantile esotropia by definition is established before 6 months of age. Esodeviation is usually more than 30 prism diopters in infantile esotropia. These patients can cross-fixate, may not develop amblyopia, but rarely have simultaneous bifoveal fusion. Their refractive errors are in the normal range, and the esodeviation is similar for distance and for near fixation. Conditions associated with infantile esotropia include inferior oblique overaction, dissociated vertical as well as torsional or horizontal deviation, fusion maldevelopment nystagmus syndrome, also known as latent nystagmus, and nystagmus blockage syndrome. Asymmetry of monocular horizontal smooth pursuit is universal in infantile esotropia and persists lifelong. Surgery is the treatment of choice for infantile esotropia and should be performed before 2 years of age. Most commonly, bilateral medial rectus recession is performed. Following successful realignment, majority of the patients achieve monofixation, which provides stable alignment of the eyes and is considered to be an acceptable surgical outcome. Following surgery for infantile esotropia, patients require long-term follow-up to detect development of associated conditions and recurrence of esotropia. Many patients require multiple surgeries during their childhood. Pseudoesotropia can occur due to a wide nasal bridge, epicanthal folds, a narrow interpupillary distance, and a negative angle kappa. But cover tests and corneal light reflex tests will show the eyes to be aligned in patients with pseudoesotropia, except corneal light reflex tests in patients with negative angle kappa. Thank you for listening.